Without further ado, I'm going to introduce my colleague, Dr. Gert Kwakkel, who's I've worked with for a number of years now, and we are very lucky to have him today to speak to us. He's come to us from the Netherlands, and for more than 3 decades, Dr. Kwakkel has played a key role in stroke rehab, looking at the dynamics of recovery post-stroke with a particular focus on intensity, and it's important for exercise. He also has been responsible for developing the Dutch stroke guidelines with respect to neurorehab and physiotherapy. And for the last 12 years, he's held the chair in neurorehab at the VU University Medical Center in Amsterdam. And in his work, he is dedicated to translational research in the field of neurorehab with a special focus on the relationship between the brain's ability to heal, or brain plasticity, and motor recovery in the early stages following stroke. So please join me in welcoming Gert. Thank you. I think this is how yours.
Thank you, Mark, for the kind words. It's really an honor standing here at the podium of the best rehab universities worldwide here in Toronto. It's really an honor for me. And I'd like to talk in this brief presentation about understanding upper limb recovery. I have no disclosures as a speaker, and I like to address 3 key questions. Can we predict upper limb recovery early post-stroke? I think this is a really important issue for targeting therapies. Can we influence the pattern of neurobiological recovery early post-stroke? What do we know about this issue? And is the amount of spontaneous neurological recovery the same for all patients? That's a key point that we like to target in the next years also. And I can best show you this in 10 patients randomly selected, and on the IX you will see there 57 points maximum is a full recovery on this action research arm test. This unilateral test, and patients have to manipulate with the hand. And it's clear in these 10 random selected patients that some patients have a very quick recovery within a couple of days, and other patients almost not. And the key question is, can we predict this? And at the same time, 10 years ago almost, 2 groups, our group and also a group from New Zealand, found out that there are 2 clinical markers that are very, very important in order to make an accurate prediction of these patients with a favorable prognosis or an unfavorable prognosis. And for that, we investigated 211 stroke patients with a hemispheric stroke, and found, as shown in this is the probability in this green line, those with a high positive predicted value of 93%, showing a favorable prognosis just on the basis of early observation of finger extension within the first 72 hours after stroke onset, and looking for a little bit shoulder abduction. And both clinical markers, known as the SAFE algorithm, shoulder abduction finger extension algorithm, are very predictive for saying, okay, this is probably someone who will regain dexterity back. And if you can use your hand, you don't have dexterity, and this is defining the functionality of your upper limb. We also found if you don't have finger extension, then the negative predicted value is 0.86, so a little bit lower. And now the challenge is how to discover these patients more accurately, just not only on the basis of the clinical markers, but also by doing, for example, transcranial magnetic stimulation, also diffusion tensor imaging. Acknowledging that this finger extension has a lot to do with some intactness of this cortical spinal tract system. However, this has to be still shown as an added value in the predictive ability of these devices. What's interesting is, okay, I have a poor prognosis when they have no finger extension, no shoulder abduction, but it's also clear the negative predicted value of 0.86, 86%. There are a lot of exceptions in this rule. And I'd like to look with you to these exceptions. And these are 91 patients not showing any dexterity and not finger extension at the onset. And these are the true negatives on the bottom. And it's clear that there are a lot of exceptions in this prediction rule. And it's interesting to figure out when does it occur, when there's a return of finger extension. And when do we know sure there's no return of finger extension, no dexterity at all, also not after 26 weeks. And doing this in a kind of survival analysis, it sounds a little bit complicated, but it isn't, in fact. It's happening mainly in the first 8-10 weeks after stroke onset. So there's a critical time window in which you have to observe the patient weekly, in fact, and that's what we're doing now following the guidelines. Say, do you have some finger extension? And if there's some return, it's happening mostly, almost 100% in the first 3 months post-stroke. And we had just one exception in this rule. Who are these exceptions? These patients that are showing an exception have more modalities involved. They have sensory deficits, they have a visual deficit in the visual-spatial neglect, and they have also more lower limb deficits. These are the true negatives. And the probability for any return of dexterity of the upper limb, it's 4%. Whereas those who has a more unimodal deficit, more pure motor hemiplegia, they have a probability of 94%. So we have a complicated algorithm, and this complicated algorithm is interesting that if you apply this and asking simply questions by saying, can you move your arm? Can you extend and abduct your shoulder? Can you extend your fingers, for example, and you're doing this weekly, then you are coming to different boxes of evidence-based practice. And that's exactly what therapists need. Because these therapies are not effective for all types of patients, but it's a selection of patients that these therapies makes most effective. So we defined, following the evidence-based guidelines, the Dutch guidelines, 12 different boxes. And the brilliant mind of Mark Bailey, who is one of the developers of this way of this algorithm, thought, okay, you can put this in an app. And so we developed a VIA therapy app in which simple questions are asked. Does the patient have shoulder pain? Can the patient extend the fingers? And is there some shoulder abduction? And you will bring automatically to a certain types of evidence-based practice. And this app has been downloaded using this algorithm many thousand times. Also for people in China or India who don't have these guidelines. Can we influence the pattern of neurobiological recovery? Important, because there's a lot of spontaneous neurological change by Mother Nature on the background. So knowing that finger extension is very important, it's important to say, okay, if there's finger extension, then probably I need to apply an effective therapy, maybe the modified constraint-induced movement therapy, compared with usual care. Or the other group who don't have finger extension within the first 8 days, we applied in this trial EMG-controlled neuromuscular stimulation compared with usual care in a randomized way. And we followed these patients also using TMS, also with fMRI, and also using kinematics in order to understand how the quality of movement is changing, and also looking to stiffness changes. I'm not showing all this stuff, but I strongly believe always, if you like to understand what patients learn by therapy, you need to do in a repeated measurement design. And so we had 8 times for the first 26 weeks, measure these patients at fixed times, doing kinematics, kinetics, haptic robots by stiffness changes, and also TMS and fMRI. So Netherlands is a quite dense population, 70 million people living together. So we work together with 4 different academic universities, the technical university as well as 5 different rehab centers and about 20 nursing homes, but most patients are discharged to home. So we're following these patients longitudinally in time in this explicit stroke trial that stands for explaining plasticity after stroke. And we hoped for, because that is the reason why you're doing these trials, to find 6 points difference in favor of this action research arm test, in favoring of this modified constraint-induced movement therapy for those that have some finger extension. And we hoped for 10% differences in regaining some dexterity who has a poor prognosis at onset just by this EMG-triggered neuromuscular stimulation. And we had also secondary measurements of outcome, and I will only show the Wolf motor function test and the stroke impact scale hand domain. But these are the primary measurements of outcome, what we say. And this is in the slide exactly showing what's happening in these patients. There is spontaneous neurological change. All patients will improve when there is some finger extension. There's a lot of spontaneous neurological change. But the interesting part, if you're doing this very intensively, very early, you can speed up these patients in their pattern of functional recovery. They're reaching higher levels, and this was clinically meaningful in favor of these patients. So modified constraint therapy, early applied, is very effective. At the end, we didn't find significant differences anymore. So we had to extend this type of therapy, not to 3 weeks, but probably for a longer period. And also on the stroke impact scale hand domain, in which patients had to report if they have benefit of this kind of therapy, there was a clinical meaningful difference favoring of this constraint-induced movement therapy. When compared to usual care. But again, there's also spontaneous change. And we didn't find on the Fugl-Meyer score differences, at least suggesting that we have difficulties in influencing neurological impairment, but we are optimizing the performance of patients during their recovery. And this finding is closely related in this meta-analysis of 51 different trials, showing that constraint-induced movement therapy is very effective for the upper limb if there's some finger extension and wrist extension. Significant effects are found. And more importantly, also on the long term at follow-up, there are significant effects favoring this type of therapy. But again, you have to select patients with some finger extension, with some intactness corticospinal tract system, suggesting that therapy isn't the law of one-fits-all principle, but just also a matter of selecting these patients that are most appropriate for a certain type of therapy. What happened with these patients with an unfavorable prognosis, not able to extend the fingers within the first 8 days? These are the true negatives, and these are the exceptions in this rule. Can we influence 10% more of these patients in their proportional recovery, enhancing this by this EMG-triggered neuromuscular stimulation? And unfortunately, we didn't. So, also suggesting there should be some potential for recovery by this intactness of corticospinal tract system in order to be effective in this EMG neuromuscular stimulation. It's also suggesting that it's selecting therapy because I believe in EMG-controlled neuromuscular stimulation, but it's rather more effective for those patients that have some intactness of this corticospinal tract. So again, there's a lot of spontaneous neurological change for improving activities, but our therapy is strongly driving this route by learning optimization, learning compensation strategies, and improving the coordination of the upper parietic limb. A final question that I'd like to address is, do all patients show this spontaneous neurological change? And since a couple of years, we know that there's a pretty nice 70% prediction rule saying that most patients following a fixed amount of spontaneous neurological change. And in this slide, we have the predicted one and the observed ones during the 6 months, but spontaneous change is mainly happening in the first 8-10 weeks as shown. And it's a prediction rule that says, okay, the amount of improvement on the Fugl-Meyer motor scale is highly predictable by taking 70 to 78% times the potential for change in this motor recovery, knowing that there are 66 points maximum minus the initial score. So you have a window for change, take 70%, and you will have pretty good estimate of the amount of change. But it's also clear that there are outliers, patients who don't show spontaneous neurological change at all. And the question is now, who are they? Can we predict this on beforehand, early? Because these patients need totally different types of therapy. And the future is, can we change the non-recovers into recovers of spontaneous? And the second is, can we speed up the spontaneous amount of change? Maybe stem cells, maybe other types of therapy. I don't know. Don't ask me, because we don't have the answer. And there's a Nobel Prize, I should say, for the future. Coming back to my finger extension, all patients with finger extension are showing spontaneous neurological change. But we also saw that patients who don't have finger extension, they make exceptions, and they are going to these recovers. And these are the true negatives, not showing any recovery at all, and they had a critical margin of about 18 points on the Fugl-Meyer arm score. So this proportional recovery rule, is it generalizable? Is it just for motor recovery? And the answer is no. It's also true for a letter cancellation task, inattention. It's also true for aphasia, patient who are recovering in their language impairment. And interestingly, those patients that show no spontaneous neurological recovery in the upper limb motor recovery, and they're also suffering, for example, from neglect. Neglect is also not recovering. So there's a kind of common system behind this, saying, okay, you are not recovering spontaneously by these underlying mechanisms. So at least for trialists who are doing to investigate this, it's important measures to say, okay, let's stratify these trials and let's select these patients better, because these patients without spontaneous neurological, they need compensation strategies, they need devices, they need another type of approach. So how we proceed now, at least in this small country, the Netherlands, looking for the modulators and determinants of recovery. And we're collaborating with the different universities, and we call this profits. And don't run away now, because it's complicated, but I will solve you. So what we're now doing is trying to say, okay, this recovery of patients, which has a nonlinear pattern in time, may have different values on different clusters. And each individual is nested in a cluster, and having this Fugl-Meyer score 66 points minus the initial score in the first days, and these trajectories may be different for each patient. It might be 70%, it might be 60%, 40%, or whatever. And each trajectory has a different time window for change. And figuring this out, I didn't solve this. These are the economic twists of the Rotterdam University. People who are doing this kind of models only. And this is interesting because we now discovered that there are 5 different groups. Non-recovers, already shown, and recovers. And these recovers are in different subgroups. And 1/3 of all these recovers are excellent recovers, 1/3 are just in this bottom, and 1/3 is in this middle. And the time course of these courses is happening about, and you see this tau is happening in 10 weeks' time. And these are the quick responders, and within a couple of weeks they are on the top, and these are the non-changes. And we found an accuracy of 86%, so pretty good. So what have to do with these complicated models? What we're now doing is having these models on the background of 412 patients, and so therapists are learned to type in, is there neglect? What is the Fugl-Meyer? Can patients extend the fingers and so on? And we have the server, and you can consult this server, and the server will give you an estimate what's happening in this patient-specific, with the 95% confidence interval, and making an immediate visualization about what is happening. So you need big data, a web-based infrastructure in order to allow making these predictions. So that's the thing where we are building now, individualized patient-specific prediction modeling, and I think this is a step to the next future, allowing to improve the discharge policies of stroke patients. When I'm asking neurologists, at least in the Netherlands, what's happening? Will this patient walk again after 6 months? They don't know. And nobody knows because it's quite complicated. But using these algorithms, you can improve it. Monitor patients' progress, feedback and motivation for training, stroke patients recovering, so you can show it to the patient. Last week you had these scores, now you have these scores, so you are improving as an incentive. Improve communication between settings, this is an issue too, between nursing homes and rehab centers. Allow benchmarking for insurance companies, seeing, okay, what type of patients are we dealing with, and understanding recovery profiles. I like to thank my team for my support, and I'd like to thank you for your attention.